Great. Well, good morning, everyone. I'm so glad to see everyone here at this event. This is really a great group of people. I'm very excited to be speaking at the Inspire event. Every year we have a group come by and make sure that our hospital is kind of up to date on all of our credentialing processes, that we're doing everything correctly, that we're meeting all the criteria to be a comprehensive stroke center. And every year they rave about the Inspire program. Every year. They're always super excited about it. They want to learn more about it. And so I'm happy to be here. So I'm Jessica Jarnot. I'm the stroke medical director for this hospital. I'm a vascular neurologist. That means I did my neurology training and then I did an extra year to subspecialize in stroke and other brain vascular problems and conditions. So today, I'll talk about what is a stroke, what causes strokes to happen, kind of things that could put someone at risk of having another stroke, how can you prevent another one, and then some frequently asked questions that I get asked when I'm in the hospital. So what is a stroke? Obviously, everyone in the room has had their own experience with this, but a stroke is a sudden neurologic event that's due to an interruption in the blood flow to the brain. And so strokes are, by definition, they're always sudden. And I see a lot of people where they think, well, did I have a stroke? Yeah, I've been getting weaker and weaker over weeks and weeks. And typically that's not. So usually a stroke is it happens one day. And everyone in this room, I'm sure, could share a story about that day that life really changed, right? And so a stroke is it's sudden. And it has to do with the blood flow. And it's either an interruption in the blood flow, so something is blocking that blood flow, like a blockage in the artery. That's called ischemic. Or it's because an artery broke open, and that's a hemorrhagic stroke. Hemorrhagic strokes are only about 10-ish% of strokes that occur. Most of them are ischemic, but both of them can affect the brain equally. It doesn't mean that one is more severe than the other. It's just that one is more common than the other. So most of them are ischemic. And then if the brain isn't getting the blood supply, then it's not getting the nutrients that it needs. It's not getting the oxygen that it needs. The longer the brain goes without blood supply, the more risk there is of some damage to those brain cells. That's why time is so important, because if there's something that we can do to undo this process, then you can save those brain cells. So the longer it goes without oxygen, the more risk there is of a permanent deficit coming from that. And so the treatments that we have to try to undo strokes, those are really very time sensitive. So what are the causes of ischemic stroke? So ischemic strokes, the cause can come from the heart. It can come from the arteries that are going up to the brain, or it can be a problem within the brain tissue itself. In the heart, when I think of ischemic strokes that come from the heart, if somebody has AFib or a heart rhythm problem, that can cause the heart to form a blood clot. Then when the heart pumps, it launches that blood clot up and it gets stuck in the artery in the brain. So it's not the brain's fault, it's actually the heart's fault. It's a problem of the heart rhythm, and so that rhythm problem puts you at risk of having a blood clot there. I've seen people who have an infection in their bloodstream. That infection goes to their heart, and then that scar tissue from the infection, that can break loose and embolize or travel to the brain. People can have a hole in the heart. It's pretty common to have a hole in the heart. 1 in 4 people have it. It's an uncommon cause of stroke. If you have a hole in the heart, then a clot from your leg can bypass through a hole in the heart and cause a stroke to happen. It's not very common, but it's something that we do see sometimes, and I'll talk more about it later as well. A stroke can be caused from the arteries in the neck as well. So if you have a lot of plaque buildup or atherosclerosis, sometimes risks for this are smoking or high cholesterol. That can either block the artery completely, or a piece of that can then travel up to the brain and get stuck in the artery downstream. Sometimes people have a tear in the artery in the neck. I see this more in people who are younger. It's a of the strokes that happen in people who are younger, it's relatively more common that is from a tear in the artery. Again, that tear in the artery can either cause a blood clot to form on it and block the whole artery, or it can travel downstream and then block it that way. And sometimes the strokes are caused by an artery within the brain itself. So these are the small arteries. Our arteries, they branch out kind of like tree branches, and they get smaller and smaller and smaller. And those end arteries, if they're always exposed to high blood pressure, they have to thicken and harden to try to resist that high pressure that goes through. And then as they thicken, they can get blocked from that. Diabetes as well causes some damage to those arteries at the ends. And so those tiny little arteries are just more sensitive. And so things like high blood pressure and diabetes can really affect the small arteries that are in the brain and cause a stroke from a local effect. So not from somewhere else, but within the brain itself. Hemorrhagic strokes, or the bleeding types of strokes, these are commonly caused by aneurysm ruptures. Most people who have aneurysms, the aneurysm never ruptures. So it's actually very uncommon. We tell people sometimes that they have an aneurysm, it's a 1% chance in the next 5 years. But if you're that 1%, right, then it happens, then it happens. And so it's tough because sometimes doing a procedure to prevent these is more risk than the risk of the aneurysm rupture. So sometimes people have an aneurysm that we coil to prevent it from even rupturing in the first place. But then you have to go through a procedure. Those procedures have risks, of course, and so there's always that risk imbalance if you know that you have an aneurysm. Most of the aneurysms that we see rupture, though, they didn't know ahead of time. They don't cause any symptoms. They don't cause headaches. They don't cause numbness. They don't cause any symptoms at all until one day when it could cause a stroke to happen. Bleeding strokes or hemorrhagic strokes can also be from high blood pressure. So like I said, the high blood pressure causes those arteries to thicken and harden, and they actually become more brittle as well. And so then that high pressure can cause that artery to pop if someone does have high blood pressure. Amyloid is another condition. It makes those arteries a little bit more leaky, a little bit more prone to having a bleed happen. And then being on blood thinners. So usually being on blood thinners itself doesn't cause a bleed, but if somebody also has high blood pressure or kind of delicate arteries already, being on a blood thinner could then make a bleed even more severe if it does happen, just because the blood is thinner and it's going to spill over more. So what are the risk factors for a stroke? So what are the things that I look at when I meet somebody in the hospital? So risk factors can be obviously high blood pressure, smoking, diabetes, high cholesterol, AFib, that's that heart problem, that heart rhythm problem. A lot of people don't know that they have AFib until they're in the hospital because a lot of people never feel it. And so we diagnose it when you are in the hospital after a stroke. Sometimes there are symptoms of it, so sometimes people are on blood thinners and they can kind of get a head start on the blood thinners when they were first diagnosed with AFib, but a lot of times that doesn't even cause any symptoms at all. Artery malformation, so this is the way that the brain develops or the brain grows. It has a little tangle of blood vessels that can cause a stroke to happen. Sometimes you'll have more, their arteries are also more delicate in the neck. Fibromuscular dysplasia, that's something that puts people at a risk of a tear in the arteries in the neck. This hypercoagulable state, that just means that you have a higher tendency to form a blood clot than somebody else might, and that is something that we can pick up on blood tests. That's something that I see more in younger people as well. Some genetic conditions and sometimes family history too. So family history is, you just know your mom or dad, they both had strokes and heart attacks and things like that, versus genetic condition is where they can actually run a blood test and say, oh, you have this exact thing. So family history it is genetics, but it's often not measurable. There's not like a test that tells you, oh, your dad had exactly this gene, but sometimes things can run in the family. Will I have another stroke? This is something that people ask me all the time. My wish is that I could tell everybody no. My next wish is that I could tell them I can tell you the exact percent, but we really don't have very good calculators of this, despite the fact that strokes have been around for forever. We don't have a great way to know if somebody will have another one or not. There is a risk calculator that sometimes your primary care physician might tell you a number. If it's Framingham risk calculator, that's the risk of a heart attack or a stroke, but it doesn't always account if you've had a previous stroke. It doesn't account things like hypercoagulable state. It doesn't account for artery malformations or anything like that. So there's a lot of kind of insufficiency with that calculator. If people who have AFib or atrial fibrillation, there is a calculator that we use a lot. It's called the CHA2DS2-VASc score. Most people, I'll say when I see them in the hospital, sometimes I'll do the numbers on my phone, but most of the time I get around 7%. So someone who's maybe over 65 and has hypertension, maybe has diabetes as well, it's usually around 7% or so. It can be as low as 2%, or it can be as high as 11%, and that's the annual risk of having a stroke. Now that number goes way down if you're on blood thinners, and so that's just the risk of stroke just from the AFib itself. The highest risk of having another stroke is within those first 90 days of having a TIA or having a stroke. That's really when the risk is the highest. If the stroke is related to a dissection, it's highly variable what you can read in the studies about how likely it is that someone's going to have another stroke. I'll say from my experience in the hospital, I see people, and I see people back in the clinic where they have a third stroke, they have a fourth stroke, but most people who I see have one stroke. So the majority of people, they have one, and everyone's journey is so different in terms of their recovery, but most people who I see have one, and then it's less common to have more and more, right? Because if we're talking about things like, well, there might be a 3% or a 1% annual risk, that's still, all things considered, relatively low. And there are things that we can do to reduce the risk of having another stroke. When I was at the university in my fellowship, we were enrolling people in a trial to see if we can get that risk of stroke down after they have a TIA or a minor stroke by giving them aspirin plus Plavix or clopidogrel. And we found that, and this was like a nationwide study to see if we can get that risk of stroke down. And now when someone comes into the hospital and they have a stroke or a TIA, an ischemic stroke, so from a blood clot, we often will give them aspirin in combination with clopidogrel or Plavix. That really reduces the risk of having another stroke within the first 90 days. Even if we do that combination just for 3 weeks, we found that this risk of stroke goes down. It goes down from about 6.5% to 5%. You might say, well, that's not a lot. And I don't think it's a whole lot either, but if that's me sitting there, well, would I rather have a 6.5% chance or 5%? I'd take the 5%, right? So that's why that it's something that we do. And we typically just do the combination for 3 weeks, because as you're on both for longer and longer, that can increase your risk of bleeding. So the top line, the blue line, is people who are just on aspirin, and that risk of having another stroke kind of jumps up just in the first couple of weeks. The second line, the red line on the bottom, that's aspirin plus Plavix. So that's only a 5% chance of having a stroke versus the 6.5. You notice that really the big difference in the two lines happens in the first couple of weeks, and then it pretty much stays the same. And so the bottom line, it's kind of hard to tell, but the bottom shows your risk of having any sort of a bleeding event, and that steadily increases if someone is on aspirin plus Plavix, and it stays lower if someone is just on aspirin. And so because that jump The main difference is in the first 3 weeks. That's why oftentimes we'll have someone on both medications just for the first 3 weeks. Staying on that blood thinner, so staying on either aspirin or staying on Plavix or staying on a newer one of the fuller blood thinners, so warfarin, Eliquis, apixaban. Those things all can reduce the risk of having an ischemic stroke in the future. Not smoking, this is a big one. So smoking is a really big risk factor for stroke, and obviously we encourage everyone to stop smoking if they are. Taking a statin or a cholesterol medication, that can help to reduce the risk of stroke. Controlling your diabetes, Mediterranean diet as well, and then having regular exercise. I'll talk more about the Mediterranean diet in a little bit too. So anticoagulation or blood thinner. So if somebody has AFib, being on a daily blood thinner like apixaban or warfarin can really help to reduce that risk of stroke down to about 1% annually. So we used to be at maybe 7%, and that blood thinner can really bring your risk of stroke down. Aspirin can help bring it down a little bit, but not quite as much as apixaban can or warfarin. So the newer ones are easier to use, they're more effective, and they have a lower bleeding risk than warfarin. So warfarin is kind of our tried and true medication that's been around for a very, very long time. And in some cases, that's the only option that your doctor will give you. But in other cases, you could use apixaban or Eliquis, which is one of the newer medications. It's similar to Xarelto, rivaroxaban. So some of the newer medications, the newer blood thinners, they're easier to use because you just take it once a day or twice a day, and it works, rather than warfarin where you have to get your blood checked and then you might be out of range, you might be too high, you might be too low. And so the newer ones are actually just a little bit better. Honestly, the biggest thing with these is insurance. Sometimes insurance will put up a stink trying to cover these, and that's something we try to figure out while somebody's in the hospital, or we try to figure out the insurance coverage before we say you have to be on that one. If you can't be on blood thinners long term, but you have AFib, nowadays what people are doing sometimes is is a procedure in the heart where they put up this umbrella type of thing in one part of your heart. It's this little appendage that sticks out that we don't really need anyway, and that's where most of the blood clots go when somebody has AFib. A lot of the blood clots kind of get stuck in this little loop that's hanging out, and so a cardiologist can go in and do a relatively safe and easy procedure where they block that appendage with this umbrella, and then those blood clots that are formed there, they can't get out again. And so that is a way to reduce the risk of stroke with AFib without having to be on lifelong blood thinners. The caveat is you have to be on blood thinners for usually a couple of months, like 3 months, while this all heals over. So you have to be able to be on it for a little bit, just not for forever. Okay, so this is a newer thing. I've seen a lot of success with it here. It's usually really well tolerated, and our cardiology team here does these really well too. So that's another thing, another option if, say, you can't be on it, you keep falling or things like that. Sometimes after someone has a bleeding event in the brain, we might consider this as well. PFO closure, this is another somewhat, it's a little bit of a newer thing, I would say. I see a couple people in clinic who had a stroke 10 years ago, and this was not an option for them, or 10, 20 years ago, and they said, well, someone told me I had a PFO, but they wouldn't close it, so can I get it closed now? And sometimes that is an option. So a PFO is a patent foramen ovale. A lot of people are born this way. Well, actually, all of us are technically born this way, and then when we start to breathe and we grow up, this hole closes. So this is a connection between the top two chambers of the heart, and that's how babies are in the womb. Then once you're born, you have to close off that connection between the right and the left atrium, so between the top parts of the heart. And in a lot of people, it doesn't close all the way. So in about 25% of people, there's a connection between the top right and the top left part of the heart. That, in theory, if you had a clot in your leg, then could allow a blood clot from the leg to pass through that connection and then travel up to the brain to cause a stroke. It's very uncommon that people have a stroke this way. And once somebody has a stroke because of a PFO, their risk as well, their annual risk of having another stroke because of that is maybe just over 1 to 2% or so. So it's not that high. But you think of that, if that happened when you're 30, then all the years of having that risk really adds up. So a cardiologist can just kind of sandwich that shut. Same cardiologist who does the Watchman can go through and go across the opening and then put a little disc on one side, put a disc on the other side, and sandwich it shut. And that way you can't get a clot from the leg going across anymore. This has been shown to be a really effective way to prevent stroke, really in the people who are under 60 who might not have other risk factors. So this isn't for somebody who's already had AFib. It's not going to prevent the AFib stroke. It's not going to prevent a stroke from smoking or from high blood pressure. But in people who don't have other risks, this can be pretty effective. And then the Mediterranean diet. So this is the only diet that's ever been shown to reduce the risk of stroke or heart attack. People nowadays are doing Atkins, or they're doing keto, or they're doing high carb, low carb, high this, high that. And really the only thing that's been scientifically proven is the Mediterranean diet. What I like about this one is that there are people who live in Greece where this is like not a diet. This is just like what they do on a normal day. Like this isn't people in a whole, country, in a whole region of the world. They're not trying. This is just kind of what they do. It's a very natural thing for people who live in the Mediterranean area. So that's what I like about it. It's not that you have to count things and be exact about it. It's a good way to eat like whole foods, real foods, not overly processed, not something that was, it used to be peas and then they turn it into a hamburger. So that's what I like about it. It's just food, and you can see at the bottom of the triangular part of it, it has whole grains, lots of fruits and vegetables. Sometimes people wonder about this with diabetes. The foods that they have like a low glycemic index. That means that these are not foods that spike your blood sugar. These are foods that kind of give you a consistent sugar kind of throughout the day. So like those starches would be whole grain pastas or whole grain breads and things like that, instead of like a candy bar or something. And so fruits and vegetables are really the base. The majority of your plate are going to be those real foods. For protein, there's a lot of fish, and there's other types of fish, and seafood is really a good source of protein. They also have protein in beans and legumes and things like that. Less common, even so, is poultry, so chicken, which chicken's all right, but they just don't have it as commonly. Eggs and cheese are also not quite as common. And then like once a month, they eat steak or red meat or something like that. So hamburger or steak, and even like the sweets, the desserts, those sugary sweets, they're very uncommon. And so as a guideline, well, how often can I eat red meat, or how often should I eat? I mean, there's not like you have to do this on Mondays and then this on Thursdays only. I try to say if you have steak once a month, then that's that should be even in accordance with this food pyramid. What else was I going to say about it? At the bottom, kind of that foundation too, is regular exercise. So whatever people can do to stay moving is really important. So the less you move, the less you can move, right? And obviously strokes, I know they cause a physical impact on a lot of people where it makes it hard for them to move. But if you're working with physical therapy and you're keeping up with those exercises, once you graduate from physical therapy, it's up to you to kind of try to maintain that level, because if you're not staying active, then those muscles aren't going to remember how to how to do the things that they used to, right? So once you work with physical therapy, you're gaining your strength, trying to maintain that, trying to have a good regular exercise, doing what you can, if that's swimming, if that's if that's biking, if that's walking, if that's even just something on a stationary bike every day. It keeps your heart healthy, it keeps your muscles going, and then the less you do with your body, the less it's going to be able to do if you kind of fall behind on some of those things. Everybody has different numbers. I think it was the most recent was like 150 minutes a week. Do what you can, right? Try to prioritize yourself. Try to prioritize staying healthy, and try to prioritize your own physical health as well. But do what you can. If some days it's just too hard, then that's what it is. But really trying to focus on yourself and staying active for your own body is very important. So what are the questions that I get asked all the time in the hospital? What's the difference between a TIA and a mini stroke and a full stroke? A TIA is a stroke that got lucky, to be honest. A TIA is where you have a blood clot, it blocks the blood flow to your brain, and then that clot resolved on its own. Your body's always making clots and breaking clots back down again, so your body broke down that clot, your brain got the blood flow restored, and it didn't leave a mark. And so you're very lucky that there wasn't more, that there weren't more long-lasting symptoms from that stroke. I think TIAs are very, very important. I take them very seriously. I take them just as serious as I do a stroke when somebody comes in to the hospital because they had a 15-minute episode where their face was droopy and their arm was weak. To me, that means we have to be just as aggressive on blood pressure control, stop smoking, diabetes, all those things, as if they were to have a permanent face droop or permanent weakness of their arm. So TIAs are very important, that we get those assessed right away, that we get somebody started on the risk reduction plan. A lot of people asked me, or they say to me, oh, I was told that I had a stroke on an MRI scan, and what does that mean? So when we do an MRI scan, there are times when we can find small strokes, or even sometimes you can find a larger stroke, and it didn't cause symptoms at the time. I personally have a hard time calling it a stroke because a stroke is a sudden neurologic event that causes symptoms. So when you kind of see that it was there, you never really had the symptoms of it, and so it's harder to really call it a stroke because if a tree falls in the forest and nobody hears it, that's kind of how I think of these things. But when I see that MRI scan and I see that somebody has had strokes on it before, maybe ones that they didn't notice, that too, I look into that and say, well, what are your risks of having a stroke that you could feel? Do you have high cholesterol? Do you have high blood pressure? Do you have AFib? Can we be looking at these other stroke risk factors to make sure that you don't get a stroke that you do have the symptoms of? And sometimes we start people on aspirin or other things too, from the brain MRI. A lot of people, this one gets me a lot. I was told that I don't need aspirin, and now you say that I do. There were a couple of years ago, the guidelines changed to where not everybody needed to be on an aspirin anymore. So a few years ago, they looked at the data. If you put pretty much everybody on aspirin, like you're over 45, you're over 50, you get an aspirin, everybody gets aspirin, right? And it used to be primary care physicians did this to everyone, and it was just routine. Well, there is a little risk of having a bleed. There's a small risk of having a GI bleed, a small risk of stomach irritations, a risk of a small bleed turning into a big bleed. And so if you put everybody on aspirin, well, people are going to have bad side effects, and you're not preventing that many strokes. If you narrow it down to people who've had a stroke or people who've had a heart attack, those are the people who really benefit more from taking an aspirin a day, assuming they're not on a different blood thinner. But the people who've had a stroke before, who've had a heart attack, those people can really benefit. You'll still get a couple of people who have bleeding, but the benefit is just larger in that select group of people. So this is something that I see a lot. And if you have had a stroke before, you should stay on your aspirin unless someone tells you need to be on something different. But you should be on a blood thinner long term if you've ever had an ischemic event, despite what they said in 2019, where now nobody's on it. You should still be on it if you've had, like I said, if you've had a stroke or heart attack any time in the past. This is something that we typically do long term. The last question I get a lot is, really, it's just aspirin. We have these long conversations about aspirin, or shouldn't you be on something stronger than aspirin? So for a lot of people who've had an ischemic stroke, we have them on an aspirin a day, and they do trials to see if something else is better than that. And it's actually about equal to Plavix or clopidogrel. Ticagrelor is Brilinta. So aspirin is pretty similar. It's not 100% effective. So sometimes if somebody does have a stroke, despite being on aspirin, we'll switch them to something else. But overall, they're pretty similar. They're not as strong as that next class, the true blood thinners like the warfarin type of things. Those are really strong blood thinners. They're a little bit different category. But in terms of antiplatelet, so these routine blood thinners that we use, the antiplatelet medications, aspirin is very similar to Plavix and Brilinta. So they're kind of on the same level, and yeah, that's what we use to help to prevent stroke, and it is very effective, even though it's not something fancy, but it still is very effective at preventing future strokes from happening. Before I wrap up my portion here, I'll just go through this BFAST mnemonic. This is someone that we want everyone to know, that we want everyone to be teaching, their neighbors, their kids, just tell other people about it as well. And it was up on that first slide too. We used to have a mnemonic for stroke that was just FAST, but in order to capture more stroke symptoms, it changed over to BFAST. So these are things how to help to know that someone is having a stroke. So it's usually sudden. Balance, so loss of balance, you're feeling wobbly, especially one side of your body is just not coordinated. Eyes, so this can be, usually it's you can't see anything to the right or you can't see anything to the left. So a change in your vision. One thing that I'll always ask whenever somebody is in the ER, did you cover one eye? Because cover one eye, if you can remember, I know there's a lot of stuff going on, but if you can cover one eye, oh yeah, I couldn't see out of my right eye, I couldn't see out of my left eye, or no, it was both eyes, I couldn't see anything out of, when I looked with both eyes, I couldn't see anything on the left. So eyesight changes can be a symptom of stroke. And then the other classic one, so face drooping, an arm weakness, you have someone hold up their arms and their arm is drooping. Speech difficulty, so they're talking and it's either really slurred or it's complete gibberish. It's just not making any sense at all. Those are all symptoms of stroke. And the T is for time. So that means it's time to call 911. The longer the brain goes without blood supply, the more chance that there is of damage. And so you really have to be as quick as you can to get help right away. Trying to think of what time trying to look at the time, someone will call you back and say, what time did your mom go down for her nap? Well, she woke up with her symptoms. What time was she last well? This is something in the ER we're always asking family members. What time were you okay? It's not about what time your symptoms started, but what time were you last fine? Because a lot of people, they wake up with symptoms and then we have to find out, well, what time did you go to bed? Or they start to speak, but were you talking all day or were you just by yourself and you didn't say anything? And then the speech started. And so time is really important, that you get help right away and that you try to remember when you were last doing well, when you were last fine. All right, and then any questions, concerns, general? Yeah, go ahead.
Dr. Jarnot, the one thing that concerns me is that you keep saying aspirin.
Mm-hmm.
But people need to know that's 81 of baby aspirin, and not to take it as a regular aspirin.
So
I think that's important.
Mm-hmm. So it's interesting that you say that, and I appreciate you pointing that out. So the question is about aspirin and the dose of aspirin. So oftentimes a lot of us will prescribe aspirin 81, and that's on maintain on aspirin 81. There was one trial that showed for people who are over 150 pounds that sometimes we'll use that higher dose, that the higher dose of full aspirin might be more effective in somebody who's over 150 pounds. And for someone who's under 150 pounds, then maybe that 81 of aspirin is enough. I don't always follow that. It was one trial that was kind of weight-based. I think a lot of things can factor into it, like age plays a big role. I typically don't have somebody who's 90 years old on a full aspirin. I would usually then use a lower dose. But if there's any questions about the dose, definitely reach out to your doctor and say, is 81 enough? Or say, is 325 too much? Okay, so it's a good thing you brought that up. Yeah.
Anything in between, like 281?
Yeah, sometimes if someone starts on the 281s, then I'm like, well, you've been doing okay. But the trial, that one study with the weight-based is over 300 milligrams a day or under 100 milligrams a day. I think in Europe they have different sizes. I think in Europe, like the tabs are different doses. They're like 150 or 75 or something. And so different countries do different things as well. But here, usually, I tend to stick with the 81 or the 325. All right. Okay, well, thanks for your time, everyone.
Thank you.